Hi, welcome to Respiratory Failure. The objectives for today's lesson are based on the QCC framework. Assessment: identify normal respiration and oxygenation. Discuss assessment parameters to determine the characteristics and severity of respiratory dysfunction. Communication: how do we utilize SBAR format and information technology to support and communicate a plan of care of a client maintained on a ventilator? Other objectives include caring interventions, identify social, cultural, and economic factors that impact care, clinical decision-making, identify and discuss interventions appropriate for the client of respiratory failure, identify nursing interventions for the mechanically ventilated client, teaching learning. How would you explain respiratory failure and the use of mechanical ventilation to clients and families? Finally, the objectives of collaboration and managing care will be reviewed. Describe collaborative management of the client in respiratory failure utilizing mechanical ventilation. Managing care. Describe the nursing management for clients utilizing mechanical ventilation. Also, identify pertinent lab tests related to respiratory failure. When we think about the respiratory system, we want to think about its purpose, which is to warm and filter air, to deliver oxygen to and expel carbon dioxide from the cells of the body. Now, let's think about the work of breathing. How does it occur? First, the air enters through the nose and the mouth, both of which are lined with mucous membranes. Fine hairs called cilia trap dirt that you breathe in. Secondly, the throat has two passages, one for air and one for food. The epiglottis, which is a flap of tissue that closes over the trachea when you swallow, is very important. When that is not functioning, patients are at risk for aspiration pneumonia. The larynx is the upper part of the respiratory system which contains the vocal cords. The trachea is like a windpipe and it directs air into the lungs. The bronchi are passages through which air enters the lungs. In the lungs, oxygen is transferred to the blood and carbon dioxide is removed from the blood. The diaphragm is a dome-shaped muscle that separates the lungs from the abdomen. Now, let's think about what happens during respiration. And let's not confuse respiration with ventilation. Respiration focuses on the exchange of gases, and ventilation focuses on the movement of air in and out of the lungs. Respiration events include breathing, moving the air in and out of the lungs, called ventilation, as just mentioned. External respiration, exchanging gases between the air in the lungs and the blood. Gas transport of oxygen to the body cells and the return of carbon dioxide. Internal respiration, exchanging gases between the blood and the body cells. Cellular respiration, using the oxygen in cell processes and the production of carbon dioxide. Respiration is regulated by chemical stimulation, pressure gradients, and neurological factors. The oxygen concentration in blood within the capillaries of the lungs is lower than the lungs' air sacs. Because of this concentration gradient, oxygen diffuses from the alveoli to the blood. Carbon dioxide, which has a higher concentration in the blood than in the alveoli, diffuses from the blood into the alveoli. Movement of the air in and out of the airways continually replenishes the oxygen and removes the carbon dioxide from the airways and the lungs. This whole process of gas exchange between the atmospheric air and the blood between the blood cells of the bodies is called respiration. The rhythm of breathing is controlled by respiratory centers in the brain. The inspiratory and expiratory centers in the medulla oblongata and the pons control the rate and depth of ventilation to meet the body's metabolic demands. Several groups of receptor sites assist in the brain's control of respiratory function. The central chemoreceptors located in the medulla respond to chemical changes in the cerebrospinal fluid, which result from chemical changes in the blood. These receptors respond to an increase or decrease in the pH and convey a message to the lungs to change the depth and then the rate of ventilation to correct the imbalance. The peripheral chemoreceptors are located in the aortic arch and the carotid arteries and respond first to changes in PO2 and then to partial pressure of carbon dioxide. Respiration has two main phases, inspiration and expiration. During inspiration, the diaphragm contracts and moves upward. The respiratory muscles contract and pull outward. The thoracic cavity expands. A vacuum is created via negative pressure. Atmospheric air moves from high pressure area outside the body to low pressure area into lungs via the trachea and bronchi. During expiration, the diaphragm and respiratory muscles relax. The thoracic cavity returns to pre-inspiratory size. Passive exhalation of air from lungs to the atmosphere occurs. Remember, inspiration is normally 1/3 of the respiratory cycle and expiration is 2/3. Factors affecting breathing. Lung elasticity. Example of poor lung elasticity is stiff lungs, which equals low compliance from pulmonary edema or ARDS. Lung compliance. Lung compliance or distendability is the elasticity and expandability of the lungs and thoracic structures. Compliance allows the lung volume to increase when the difference in pressure between atmosphere and thoracic cavity create a pressure gradient, causing air to flow in. Factors that determine lung compliance are the surface tension of the alveoli, normally low with the presence of surfactant, and the connective tissue, such as collagen or elastin of the lungs. Airway resistance affects breathing and increases with mucus. Air pressure changes also affect breathing, but are not going to be discussed in this lecture. Oxygenation. Oxygen is carried in two forms in the body. 97% of oxygen is bound to hemoglobin. Measurement by oxygen saturation is called pulse oximetry. The normal range for this is 95 to 100%. 3% of oxygen is dissolved in plasma. This is measured by ABG, specifically your PaO2. The normal range for your PaO2 is 80 to 100%. This is a picture of a pulse oximetry machine. This is a non-invasive method to monitor the oxygen saturation of the blood. It doesn't replace ABGs. As mentioned earlier, the normal level is 95 to 100%. May be unreliable. Think about some factors that might cause this to be unreliable, such as poor peripheral circulation. This is simply a table delineating the relationship between PaO2 and SaO2. For example, if your PaO2 is 100%, your SAT is 97. Now let's go down to the bottom number. If your PaO2 is 30, your SAT is 60. So you really want to think about those low saturations and how they correspond to your PaO2s when examining and assessing patients. This is an oxygen administration flow system table. Nasal cannula can go from 1 liter to 6 liters, and the corresponding percentages of oxygen are listed. 6 liters will give you up to 42% oxygen. So think about that patient that refuses to have a mask on and needs 40%. You could go as high as 6 liters, but remember it must be humidified because oxygen is very drying to the mucous membranes. Your partial rebreather, 50 to 75% FiO2 it's going to give you at 8 to 11 flow rate. And your total non-rebreather should be at a flow rate of 12, and it'll give you from 80 to 100%. And that's the one you want to grab when your patients are in trouble. You don't want to play around with the nasal cannula. You want to go straight for the 100% non-rebreather. This is simply a chart of oxygen administration systems, high flow systems. Example, Venturi mask, 4 to 6 liters, 6 to 8 liters, and correspondingly on the right-hand side is the oxygen percentage that those liters will equal. So when you talk about a Venturi mask, you don't want to say that a patient is on 6 liters of Venturi mask. You want to give the percentage. They're color-coded, and it will say specifically 6 liters equal 35%, 8 liters will equal 40%, and that's the information you want to give in your SBAR report. Trach collar, same thing. Very often students will mention that a patient is on 8 or 10 liters trach collar. That's an inaccurate statement. What you want to say is the percentage of the oxygen they're on. So it is what the flow rate by liters equals in percentage. For example, 8 liters might equal 40% FiO2. And again, that's the information you want to give in your SBAR report. Phase 10, mainly used for children, not so much in adults. T-pieces, not used so much anymore, but you still might see them in some institutions, really used for weaning patients off the ventilator. Bag valve mask, as we all know, is an ambu bag. The flow rate should be from 10 to 15 liters, and it correspondingly will give you 100% FiO2. This is just a simple question. Which of the following is the most reliable and accurate method for delivering precise concentrations of oxygen through non-invasive means? Nasal cannula, transtracheal oxygen catheter, Venturi mask, or your non-rebreather mask? Look at your previous slide to figure out the answer. Now that we have a foundation on how the normal respiratory system works and how gas exchange occurs, let's talk about respiratory failure. This is a life-threatening deterioration of gas exchange function of the lung. Cardinal signs: hypoxemia, a PaO2 of 50 to 60%, and hypercapnia, a PaCO2 of 50% or greater, related to impaired ventilation. Exchange of O2 for carbon dioxide in the lungs can't keep up with the rate of oxygen consumption and your CO2 production by the cells of the body. Again, this is an emergency. Comparison of respiratory failure. Acute respiratory failure, cardinal signs are PaO2 less than 50, PaCO2 of greater than 50, a pH of less than 7.35. Happens acutely. Heart failure, pulmonary embolism, acute exacerbation of asthma are some causes of acute respiratory failure. Chronic respiratory failure is a slow deterioration in gas exchange function of the lung that has developed insidiously or has persisted for a long period of time after an episode of acute respiratory failure. Let's talk about some signs of hypoxemia. Early signs would include a PaO2 of 50 to 60, restlessness, dyspnea, which is rapid respirations, hypertension and tachycardia, mild confusion or impaired judgment. Intermediate to late signs would include confusion that is worsening, dyspnea that is worsening, cyanosis, acidosis, hypotension, dysrhythmias due to the hypoxic state, diaphoresis, coma, and eventually death if left untreated. Let's talk about some causes of respiratory failure. Decreased respiratory drive related to brain injury, multiple sclerosis, Guillain-Barré syndrome, myasthenia gravis, central nervous system injuries or disorders, such as a traumatic brain injury, hemorrhage, ischemia, infection, sedatives, severe hypothyroid, pneumothorax, pneumonia. Some others might include an asthma exacerbation, post-anesthesia. Patients can't bounce back from that due to some underlying lung condition related to smoking or emphysema. So these are just a few causes. These are not all of the causes, but just a few. This is a slide of a cartoon that speaks to respiratory dysfunction. On here, you'll see some of the things that you need to assess in the client that you suspect of having respiratory dysfunction. There are some interventions here, such as fluids, suctioning, coughing and deep breathing, positioning, administering O2, administering expectorants, ambulating the client, obviously if they can ambulate and they're not in a full-blown respiratory failure. Cellular death is something we want to prevent. We might utilize testing such as ABGs, pulmonary function, hemoglobin, and hematocrit. Again, we're looking for clinical signs and symptoms to help make our diagnosis. What's the history? Has their pulse ox been going down? Speak to the early and late signs of hypoxia, which we mentioned earlier. And in addition to signs in kids, which is nares, flaring, grunting, stridor, maybe problems with feeding. So just review this slide. It helps to pull everything all together. Now we're going to talk about acute respiratory distress syndrome, a specific type of respiratory failure. This clinical syndrome is sudden, progressive, non-cardiac pulmonary edema. The chest x-ray very often shows bilateral increased infiltrates. There is acute lung injury, which causes an inflammatory response, which results in alveolar capillary membrane damage. The damaged capillary leaks into the alveolar interstitial space and alternate capillary bed. The fluid enters the alveoli, diluting the chemical surfactant and deactivates it. This loss of surfactant decreases lung compliance and causes a syndrome of small lung, which is simply an area of decreased gas exchange. The lungs aren't physically shrinking. It's just a decreased area for gas exchange. During ARDS, the alveolar collapse and there is increasing atelectasis. Gas exchange is markedly impaired. Cardinal sign: hypoxemia, refractory, or resistant to supplemental oxygen. In other words, you could have these patients on 80% FiO2 and their PO2 will still be 50 or 60%. PaCO2 rises as diffusion is impaired. The hyaline membrane form reduced gas exchange and compliance followed by fibrotic changes in the lung. Intra-alveolar septal thickens and alveolar surface for gas exchange decreases. This is a diagram of what occurs in ARDS, from the acute lung injury to all of its manifestations. Review it. It'll help you to have a better understanding of what's actually going on with the ARDS patient. What are some of the clinical signs of ARDS? Well, generally speaking, it occurs 12 to 48 hours after the initiating event. Arterial hypoxemia, unresponsive to oxygen, as discussed earlier, is one of the cardinal signs. Bilateral infiltrates by X-ray, another sign. Lungs are fibrotic. There is greater than a 50% mortality. Intercostal retractions occur. Crackles throughout the lung fields. What's involved in the management of ARDS? Well, first we must identify and treat the underlying condition, whatever that might be. Supplemental oxygen is utilized. Mechanical ventilation, as the condition worsens, is very often utilized. High percentages of oxygen initially. Pressure-limited approach. Low or moderate high PEEP to treat hypoxemia. We will discuss PEEP and the other areas of mechanical ventilation a little bit further on in this lecture. Increase functional residual capacity and reverse alveolar collapse by keeping the alveoli open. That's where the PEEP comes in. Just to mention, PEEP is positive and expiratory pressure. It's to help promote gas exchange at the end of the cycle of respiration. We want to improve arterial oxygenation. We want to reduce the severity of the ventilation perfusion imbalance. Further management of ARDS includes circulatory support, adequate fluid volume, and nutritional support. Systemic hypotension can occur due to hypovolemia from the leakage of fluid into the interstitial space, a type of third tissue spacing, and depressed cardiac output from high levels of PEEP, which is again positive and expiratory pressure. Pulmonary artery pressure catheters are utilized. Prone position is utilized. Frequent position changes. Steroids to decrease the inflammatory process. Neutrophil inhibitors. Pulmonary specific vasodilators. Surfactant replacement therapy. Just some of the management strategies utilized for the ARDS patient. Now let's talk about mechanical ventilation. And before we talk about mechanical ventilation, let's think about, why do we intubate patients? Well, some of the reasons include the patient has an inability to oxygenate and ventilate, to protect the patient's airway. The work of breathing is more than the patient can maintain. There are different ways to intubate patients. Nasotracheal is used for trauma victims. Endotracheal, which is the tube down your throat, is used for the majority of patients. and that can stay in for 7 to 10 days. Cryothoracotomy, which is an emergency procedure. It's an emergency incision through the skin and the cryothyroid membrane to secure a patient's airway during certain emergent situations. And this very often would be done in the emergency room. And a tracheostomy, which is for longer term use. Just to talk a little bit about endotracheal intubation and when do we progress to tracheotomies. Endotracheal intubation is the usual first line way of managing the patient in respiratory failure. They have that low PO2, that high PCO2, their SATs are low, they're in distress, they can no longer breathe on their own, and they need help from the ventilator. And how are we going to get that ventilator to help them? We're going to intubate them through an endotracheal tube. Now that tube sits on the larynx. The danger with that is for long term, the larynx can have severe edema and the patient will be unable to vocalize. So after 10 days, around 2 weeks, we start to talk to the family and develop a plan of care that will include a tracheostomy, knowing that they can't stay on that ET tube for a longer period of time because it will damage them for the long term. Let's talk a little bit about BiPAP. We're seeing an increased use of BiPAP as a midway procedure to try to help prevent patients from being mechanically ventilated. It's a non-invasive therapy. It's a biphasic positive airway pressure. You see patients with a version of this at home being utilized for sleep apnea. It's administered by face mask, neonates by nasal cannula. It decreases the work of breathing, and it's the best O2 delivery for patients that refuse intubation, or patients that you feel that once they're intubated, they're never going to get off the vent due to their underlying poor lung compliance issues. This is just a picture of an endotracheal tube to help you visualize how the tube sits inside a patient's throat. Notice at the bottom there's a white circular area. This is a balloon similar to other balloons that you've seen on Foley catheters, on tracheostomies, that helps the tube maintain its position. Very important that that balloon is not overfilled so that necrotic tissue doesn't develop at that area, and this is checked by respiratory. Let's talk a little bit about different types of mechanical ventilators. Initially, negative pressure or iron lungs were utilized throughout the world. These are external, non-invasive devices in which the patient lays in the device, feet at one end, head at the other end, and work by negative pressure to help the patient to breathe easier. Not widely utilized anymore, but still available. What is widely utilized are positive pressure ventilators. That's the ones we are going to be dealing with. And within positive pressure ventilators, you have different types of cycles that are utilized. Pressure cycled, time cycled, or volume cycled. And what that simply means is what is going to trigger the ventilator to initiate a breath for the patient. Is it when the ventilator reaches a certain pressure? Or what is it when it reaches a certain time? Or is it when it reaches a certain volume? Then it's going to initiate a breath for the patient. This is just a picture of positive pressure ventilators. Puritan Bennett is a very common type of ventilator that is utilized throughout the world, but it is not the only type of ventilator. This is just a picture of a Puritan Bennett to familiarize you with how they look. This is another type of Puritan Bennett, an older one. In some institutions you might still see them around. They are workhorses, they last for a very long time, but they are definitely being replaced by the Puritan Bennett 840, which is a computerized type. Pressure cycled ventilation, preset pressure flow stops when pressure is reached. Airway resistance can decrease tidal volume delivery, mainly used in infants, but you might see it used in some adults, particularly in ARDS patients. Time-cycled ventilation, Gas flow delivered over a preset time, regulated by length of inspiration and airflow, major use in newborns and infants. We don't see it that much in the adult population. Volume cycled ventilation, preset volume, tidal volume of gas delivered. This is the most common form of ventilation. This is the one we see most frequently with adults and the one we'll be spending a little bit of time now talking about. Now we're going to talk about ventilator settings, the mode, the rate, the tidal volume, and the FiO2. These are the most important settings for you to initially become familiar with. There are other settings that we will discuss a little bit further down the line. Modes of ventilation: CMV, controlled mechanical ventilation; AC, assist control ventilation; SIMV, synchronous intermittent mechanical ventilation; CPAP, continuous positive airway pressure, now known as the spontaneous mode of ventilation; PCV, pressure controlled ventilation. The discussion of these modes of ventilation will continue in depth as this lecture progresses. Adjuncts to ventilation: PEEP, positive end expiratory pressure. This is pressure that is given at the end of expiration to promote gas exchange at that point. Pressure support, also pressure, generally given during the inspiratory cycle to help to decrease the work of breathing and help facilitate gas exchange. Now let's talk about ventilator settings such as rate. The rate of mechanical breaths per minute is initially set at 10 to 14 breaths per minute. However, the total respiratory rate is what the patient is doing on their own plus what the machine is giving them. So if the patient's rate is set at 14, but their total respirations are 20, the patient's respirations are 6. The respiratory rate is adjusted based on the pH and the PaCO2. For example, if you have a very elevated PaCO2, you might want to increase the respiratory rate to help the patient blow off that CO2 and help to normalize the pH. Other ventilator settings include the tidal volume. The tidal volume is simply the mLs of gas delivered with each mechanical breath, and it is figured out by calculation of 5 to 12 mLs per kilogram. The usual setting is 500 to 750 mLs, although we're seeing lower tidal volumes now because the research has shown us higher tidal volumes cause bariotrauma to a patient's lungs. So trauma to the lungs from high tidal volumes. So we're definitely seeing lower tidal volumes as a result of that research. To higher volume risks overinflation, to lower volume risks atelectasis. Set the minute ventilation. Minute ventilation is not something we're going to be talking that much about, but it should be less than 10 liters per minute. And it's something that respiratory very heavily looks at, not so much nursing. Ventilator settings, FiO2. Fraction of inspired oxygen concentration. Range from 21% to 100%. When somebody is emergently intubated, they would generally start at 80 to 100%, they meaning respiratory therapy. Decrease by 10% until below 50%. You want to try to maintain that patient between 30 and 40%. An FiO2 of greater than 50% for extended periods of time is toxic to the lungs and causes fibrosis of the lung tissue. So, very important piece to remember. We don't want to keep these patients on an FiO2 of greater than 50% for greater than 24 hours because we know that fibrotic tissue will begin to form. We will see patients, however, that can no longer oxygenate at a level of 30 to 40% FiO2, and therefore the only way to actually keep them alive is to keep them on these high FiO2s, knowing that the prognosis is poor with these types of patients. Now let's talk about the CMV mode of ventilation. This is a controlled mode of ventilation and is not utilized so much in the hospital setting anymore. It has been taken over by assist control. Assist control has now become a combination of CMV and assist control. So let's differentiate between the two. CMV, patient can't initiate a breath on their own. They have a preset tidal volume at a preset rate. The initial setting is done after intubation because these patients can't breathe on their own. They have no respiratory effort. It's to decrease the work of breathing and oxygen consumption. However, through research we have discovered that most patients, even in a semi-comatose state, do want to initiate a breath. And it's very difficult in this mode of ventilation for that patient to initiate a breath. They are now fighting the ventilator. So what has been developed is assist control. So the difference between CMV and assist control is that assist control will have the same settings of a preset tidal volume at a preset rate. However, it will allow the patient to initiate a breath at a preset tidal volume. But it will allow that patient to initiate the breath. So no longer do we have this patient fighting the ventilator, or something called bucking the vent. So now let's review assist control mode of ventilation. This is again a mandatory mode of ventilation similar to CMV. It is an initial mode when patients are first intubated. Generally speaking, the patients are weak and have fatigued muscles because they are no longer able to handle the work of breathing. There's a preset tidal volume is delivered with patient initiation, and a preset rate if the patient does not initiate a breath. So, just to review, the patient a weaning mode of ventilation. Generally speaking, the respiratory rate is from 6 to 12 breaths per minute. And within this mode of ventilation, you will begin to see the adjunct of pressure support. Pressure support can be dialed in between 5 and 20 is the normal range. It artificially expands the lungs, thereby helping to promote gas exchange through inspiration and expiration, which is where it differs from PEEP, which is at the end of expiration. Both pressure adjuncts. This is just to help with the work of breathing and to help to wean the patient off the ventilator. Now let's talk about CPAP. CPAP is the last mode of ventilation that the patient is placed on prior to coming off the vent. It is again a weaning mode of ventilation. It is now called a spontaneous mode of ventilation. The patient must be able to breathe spontaneously to be placed on this mode. It maintains positive pressure throughout the respiratory cycle, both inspiration and expiration. There is no preset tidal volume. It can be used by a mask or a ventilator. The patient does get a preset FiO2 and pressure support. So they do not get a preset tidal volume. They do not get a preset rate. They must be able to breathe on their own. It is the final mode of ventilation prior to coming off the vent. Pressure-controlled ventilation. The expiratory phase is longer than the inspiratory phase. There is an inverse I/E ratio. Normally it's 1 to 2. Here it's 2 to 1. It's indicated for non-compliant lungs requiring high airway pressure, such as patients with ARDS. Can also be used with patients who have had lobectomies and are having difficulty oxygenating. The tidal volume may vary. It's not generally tolerated well. Sedation is generally needed, and again, it is not the most common form of ventilation. It's used in select complex cases. Other important settings to discuss are pressure support ventilation. We've already discussed pressure support within the weaning modes of ventilation, such as CPAP and SIMV. It is an adjunct to ventilation. It assists spontaneous breaths with positive pressure during the inspiratory phase. It reduces the work of breathing, and it's used with SIMV, PEEP, and CPAP. Other ventilator settings that we don't deal with routinely but are nice to know include the inspiratory to expiratory ratio, which is normally 1 to 2. It can be reversed in pressure-controlled ventilation. The flow rate, which should generally be set about 60 liters per minute. Its sensitivity, which is typically set about -2 centimeters of HTO. Too high a setting will cause weak patients to be unable to trigger a breath. Too low a setting may lead to overventilation. Peak inspiratory pressure. This is one setting we should definitely be familiar with as bedside nurses taking care of ventilated patients, because this number lets you know when a patient needs to be suctioned. Normally, 30 to 35 centimeters of HTO are needed to achieve maximum inflation. When above 60, suctioning is required. Other vent settings include PEEP, positive end expiratory pressure. This maintains positive pressure at the end of exhalation, decreases the work of breathing, promotes gas exchange, is usually between 5 and 20 centimeters of water. At increased doses can cause barrier trauma and also can cause increased intracranial pressure. Question: tell whether the following statement is true or false. PEEP is utilized as a treatment for ODS because it improves ventilation perfusion. Look at your previous slides to answer this question. Troubleshooting. Never ignore any alarms. Important vent alarms include apnea, high pressure, and low pressure. We will discuss how to intervene for these specific alarms a little bit further on in the presentation. However, it is important to mention if the patient is not being ventilated appropriately by the ventilator, and this can happen, machines do fail. Patients do develop mucus plugs in which they can't be ventilated appropriately. The right thing to do would be to take the patient off the vent, start ambuing them with a bag valve mask while you're trying to identify what the problem is. They will probably need some suctioning and some lavaging of saline at that point as well. The whole idea is to keep the patient's airway patent. Troubleshooting some specific alarms. High pressure alarm. Coughing, secretions, fighting, or bucking the vent will make this alarm go off. Suction the endotracheal tube or the trach. Avoid kinks or the patient biting down on the E-tube. Low pressure alarm. Leak or disconnection will cause this alarm to go off. Check the cuff pressure, deflate, reinflate, and reconnect any disconnections. Low exhaled volume. Check an ABG and check a SAT. Apnea. Assess patient. Use bag valve mask with 100% O2. Suspect oversedation or possibly a mucus plug. Now let's discuss the uses of a tracheostomy. It is used to bypass the upper airway or to bypass an obstruction, allows removal of secretions, permits long-term mechanical ventilation. The ET tube can only stay in 10 to 14 days, prevents aspiration of secretions, or replaces an endotracheal tube. Some complications of a tracheostomy can include bleeding, pneumothorax, aspiration, subcutaneous or mediastinal emphysema, laryngeal nerve damage, and posterior tracheal wall penetration. Types of tracheostomies include fenestrated trach, either cuffed or cuffless, which allows patients to vocalize due to the openings in the trach, a non-fenestrated trach, which is the most common type, and XLT, which is an extra long trach to compensate for patients with larger airways. In addition, speaking valves can be utilized in stable patients, usually along with fenestrated trachs, to promote vocalization. Some important interventions for the mechanically ventilated patient include suctioning, nebulizer treatments, chest PT, turning and positioning Q2 hours, humidification, and hydration. During the suctioning procedure, you must always utilize 100% O2 before, during, and after. Suctioning will be increased when the patient is newly intubated. The pressure should be between 80 and 120 millimeters of mercury. But in some institutions, the suctioning apparatus is old, and you might have to increase the suctioning pressure in order to complete the procedure. You should position the patient in a semi-Fowler's position to facilitate movement of secretions. Prior to suctioning, the nebulizer treatment might help to loosen up secretions as well as chest PT, the turning and positioning, humidification, and hydration. Other important considerations in nursing care of the mechanically ventilated patient include a full assessment, including your vital signs, lab values, x-rays, pulse oximetry, and end-tidal CO2 monitoring, which is an external device which sits between the mechanical ventilator and the tracheostomy, allowing for a non-invasive way to measure your PCO2. Eyes and nose are important. Assessing a patient's mobility, skin, nutritional consult, teaching. Along with the skin and nutritional consult, you want to look at a patient's albumin and prealbumin, because when these values are low, it puts them at risk for increased skin breakdown. And since these patients are generally totally bedridden, we really want to pay close attention to that and prevent and intervene as soon as possible. Application of suction during tracheal suctioning should not exceed 15 seconds. The answer is true. Endotracheal cuff pressure should be maintained between 15 and 25 millimeters of mercury. Let's think about criteria for weaning. The patient must have spontaneous respiratory effort. The tidal volume should be more than 3.5 mLs per kilogram for weaning. The PaO2 should be greater than 50 to 60 millimeters of mercury. The FiO2 should be less than 40 to 50%. PaCO2 should be less than 40. The patient should be hemodynamically stable. There should be absence of infection, acid-base imbalance, hyperglycemia, dysrhythmias, acute renal failure, anemia, fever, excessive fatigue. During the weaning process, patients are changed from mandatory modes of ventilation to weaning modes of ventilation. These mandatory modes of ventilation include CMV and AC. The weaning modes of ventilation include SIMV and then eventually CPAP, which is now called the spontaneous mode of ventilation. During the weaning process, the patient's mechanical respirations are decreased based on their effort and quality of respirations. Increased pressure support is utilized during the weaning process, but that too must be titrated off as the patient begins to spontaneously breathe more and more on their own. During the weaning process, patients are very often placed back on the previous mode of ventilation to help them rest and to have successful weaning trials. Indicators for weaning. Patient is tolerating weaning if the respirations are less than or equal to 28, the heart rate is less than 120, O2 sat is greater than 90, end-tidal CO2 is less than 50. Any elevation above guidelines, return patient to previous setting. Your nursing assessment of a patient being weaned from a ventilator would include monitoring for accessory muscle use, diaphoresis, restlessness, dysrhythmias. If the patient tolerates being off the vent for 48 hours and all their vital signs are within normal limits, the mechanical ventilation will be officially DC'd. Other weaning would include sizing down the tracheostomy tube, changing the tracheostomy tube to a fenestrated tube for talking. This would be in a very stable patient, and eventually pulling the tube. If there is a failure to wean the patient, then the patient will need to be placed in a long-term care center, which could be a nursing home or some type of respiratory care facility or home with support services. Patients do go home on small portable ventilators. Rarely, but it does happen. Some important nursing diagnoses to consider for the mechanically ventilated patient are alteration in gas exchange, risk for infection, risk for aspiration, alteration in skin integrity, knowledge deficit regarding disease process. There are others. Think about them while you read the rest of this presentation. Arterial blood gases. Why do we look at arterial blood gases? because it assesses the ability of the lungs to provide adequate oxygen and remove carbon dioxide. The arterial oxygen tension, PaO2, indicates the degree of oxygenation of the blood, and the arterial carbon dioxide tension, PaCO2, indicates the adequacy of alveolar ventilation. Also assesses the acid-base balance. ABG studies aid in and the ability of the kidneys to reabsorb or excrete bicarbonate ions to maintain normal body pH. ABG review. Normal pH 7.35 to 7.45, indicator of hydrogen ion concentration. Normal PaCO2 35 to 45 millimeters of mercury, indicator of carbonic acid. Normal PaO2 80 to 100 millimeters of mercury. Normal SaO2 95 to 100. Normal bicarb 22 to 26 milliequivalents per liter, indicator of bicarbonate. Normal ratio of bicarbonate to carbonic acid is 20 to 1. Metabolic acidosis, characterized by increased hydrogen and low plasma bicarbonate, occurs in renal failure and diabetic ketoacidosis, methanol toxicity, starvation. pH is decreased, bicarb is decreased or normal PaCO2. Compensation, lungs eliminate CO2 and conserve bicarb. Respiratory acidosis, due to inadequate excretion of CO2, occurs with ARDS, pulmonary edema, sedative overdose, and any disease that impairs respiratory muscles. Decreased pH, increased PaCO2, increased or normal bicarb. Compensation, kidneys eliminate hydrogen and retain bicarb. Respiratory alkalosis, due to hyperventilation, related to anxiety, hypoxemia, gram-negative sepsis, inappropriate vent settings. Decreased PaCO2, decreased or normal bicarb, increased pH. Compensation, kidneys conserve hydrogen and excrete bicarb. Metabolic alkalosis. Most common cause is vomiting or gastric suction with loss of hydrogen and chloride ions. Increased pH, increased bicarb, increased or normal PaCO2. Compensation, the lungs decrease ventilation. To increase PCO2, the kidneys conserve hydrogen to excrete bicarb. We will review the ABG cases in class. Try them on your own. Now we're going to talk about the dope mnemonic. All the previous cases listed in this presentation will be discussed in class. If you have any questions, please review and bring them with you to class. The dope mnemonic. D. Dislodged. The oxygen pipe or endotracheal tube is not connected to the lung pipe, trachea, or windpipe. O. Obstructed. The oxygen pipe is no longer delivering oxygen due to a blockage, or there could be a P. Pneumothorax. Tension pneumothorax. The pressure in the chest due to an expanding airspace outside of the lungs. This expanding airspace in the chest is preventing the lungs and heart from working properly, even though the oxygen is being delivered. The problem is not with the pipes. The solution is a needle decompression, or if it will not significantly delay treatment, a chest tube. E stands for equipment, an interruption in the oxygen supply. Anything that causes the ventilator to stop delivering gas under pressure to the endotracheal tube or tracheostomy tube. Think about your priority nursing diagnosis for the patient in respiratory failure who is on a mechanical ventilator. I hope this audio recording has been helpful. See you in class.